Recording in progress.
So we are recording now. So tonight we're going over, like I said, chapter 17, Respiratory Emergencies. Um, this chapter gets a little more in depth with emergencies, and we're going to start getting in now more in depth to these assessments and the mitigation of certain types of illnesses and injuries. So this is where we're really starting to get into the meat and potatoes of the job, the position. Uh, so this will be a pretty good deal. Mr. Martinez, are you more on the law enforcement side of EMS on, or as far as career wise? Okay. Uh, will you be taking TECC or anything like that after this, or have you already taken it? Uh, or we call it T Triple C, Tactical Casualty Combat Care. Um, tactic, yeah. Okay. So you were military. Okay. Cool. It's a fun class, isn't it? If you had a fun if you had a good instruction, it's a fun class. So so that's pretty good stuff. Yeah. The T Triple C course that I took, the very first one I took, it was kind of crazy. It was years ago. So you did the T Triple C in the 3 day time frame, but they stretched it out. So you got PHTLS, T Triple C, and you got a couple other things that were thrown in there. So it was 10 days altogether of tactical casualty combat care, and respiratory was a pretty big portion of it. Bleeding, of course, shock, bleeding, and respiratory injuries were a big portion of it. So you really get into the quick mitigation of those types of injuries, right? How to patch it up and get out of there. So that's one part. When I teach T Triple C classes to some of my students in another career field that I'm in for the military. Yep, yeah, that's what most every. Yep, that's it. So when we teach these other career fields in the military about March and what have you, then that's a big deal. So massive bleeding, airway, and that's where you start off at. So it's a little different, but it's meant for austere conditions and in higher acuity type patients is mainly what you'll have in those instances. It was pretty cool how they did it because they used to set up an IED lane, and then we had EOD come out and set up traps and everything else. And it's pretty entertaining. Sometimes, sometimes entertaining. But we may hit on a few things that not so much that you'll see in a battlefield, but that you may see in car wrecks and things like that. Some of these injuries we may get into coming up in these chapters. I really like teaching to that, so that's why I talk about it now. Is I really like kind of teaching to that type of medicine. So we'll start. You may hear me hit on things, and we'll go on that route. All right, moving on. Right. I was actually trying to buy up time. We have one or two people that are going to be joining us just a little late, but that's okay. All right. here's some of your National EMS Education Standard competencies. What we'll be going over. Basically, it's pretty much everything that's in your chapter. Introduction. So, introduction. Dyspnea, difficulty breathing, right? Difficult. Apnea would be absence of breathing, right? So, it is a complaint that you are going to encounter quite often, breathing difficulty. I know we try to, in the fire department side, we try to use the dispatches, whatever dispatch's initial tone out is for us, or what their initial, somebody help me, I'm forgetting the term. This has been all day. So what they initially dispatch us out for, the chief complaint that we receive from dispatch coming out. So a lot of times, you kind of grade who you're going to send for that, or what type of response that you need for the different types of medical patients that you may, or the acuity of the patient that you are being toned out for. So anyway, it never fails. In theory, that's an excellent way to set things up. We're only going to send these type of medics or these type of trucks to these type of incidents, and then you get the tone out, and every single one of them, it seems like on some days, is difficulty breathing, or chest pain, over and over. And so some say that it's because they know that you'll get there faster, which is not true, and they also know that you'll get on the ambulance faster and get to the hospital faster, which is also not really that true. It's based on assessment, right? And you get to the hospital, you can be dropped off in the ER, or you can be dropped off at triage. It's all just the same. You can. I've dropped people off and had them send me, or I've had the hospital file me into triage and ask me to set them out in the lobby. And so set them out in the lobby, and then I've had the nurse come out and say, all right, here's where you'll sit, and tell the patient that they'll sit right there in the lobby where everybody else are sitting. So it's one of those things that, that it's hard to convey that to the populace, but it does happen if you've ridden on the ambulance before. So the symptoms of many different conditions, from the common cold and asthma to heart failure and pulmonary embolism, is some of the stuff that come with difficulty breathing, that have a difficulty breathing attached to it. Several problems occurring at the same time may also contribute to a patient's dyspnea. Whether or not you can determine the cause, you still may be able to save that life, depending on if you can determine that cause, just by mitigating that difficulty breathing. So keep possible medical problems in mind as you obtain a history and perform a physical assessment on that patient. Regardless of the cause, the sensation of not getting enough air can be terrifying to patients. So you'll need to treat the symptoms and as many of the underlying problems as you can figure out, and the anxiety caused by dyspnea. So a lot of times, using a calm, even tone when you speak to them. What I like to call my late night DJ voice. So when you talk to that patient, Mr. So and so, my name is Chase Edwards. I'll be your paramedic. Do you mind if I check you out? Hey, I just need you to breathe in through the nose, out through the mouth. In through the nose, out through the mouth. And when you talk to that patient like that, and you talk to them in a cool tone and a cool, even tone, then that's really going to help them calm down. It's also going to help you build a rapport with that patient, because they see you being calm, cool, and collected, and maybe it would be okay for them to be calm, cool, and collected. Okay? So my wife, she makes fun of me when I make that tone of voice, because she says it doesn't sound natural, because she knows that I'm wound tight, and for me to make that type of voice, the late night DJ voice, she says it's fake, because she knows what I really sound like. I speak way too fast and everything else. So, but you have to get that tone in order in order to get someone to calm down. All calming someone down, or all patient assessment is in some aspects, is negotiation, right? So you use that tone in negotiation because you're negotiating whether that person's going to calm down and let you do what you need to get done. You're negotiating on whether that person does need to go to the hospital, so on and so forth. All right. Next. All right. The anatomy and physiology review. We have went over this on several occasions, so I'm not going to beat a dead horse, right? Unless somebody just doesn't get it. If somebody doesn't get it, let me know, and we will go over it. No problem. So you can see all this respiratory system, what all it consists of. The gas exchange, we've talked about that. Where does the gas exchange happen? Right? Let me turn my little laser pointer on here. Right? Gas exchange. Especially here. And then the cutaway so you can see the alveoli. I laughed at myself so hard after that last class. I actually laughed about it today in Monday's class. Whenever I was reading that word, I knew what that word was, and I couldn't figure out why I couldn't read it. It's like I was having a stroke moment, and I was like, Cantray. And who was it? Was it Leanne or Hannah once said that it's sounds like canker? And I was like, oh my gosh. That's silly. I knew that, and I was like, man, I screwed that up. I wouldn't believe anything I say from now on. All right. I would joke. I ragged on myself about it today. So yeah, exactly. I ragged on myself about it today. So I was talking to somebody. All right, a little bit bigger of a picture for the gas exchange. So you can see that the deoxygenated the deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries. Okay? And then the gas exchange takes place in the capillaries, covering the alveoli. And oxygenated blood is carried from the lungs to the heart by the pulmonary veins and venules. All right, arteries are blue, veins are red. Yeah, it was crazy. So, and this is why I say that pathophysiology is so important. Is that if you can break down the pathophysiology of why somebody's having difficulty breathing, then you stand a much bigger chance of figuring out exactly what's wrong with them. Because if you're anything like me, I picture what's going on. So I would actually picture this happening. I would actually picture this gas exchange and what could be creating the issues. Or if I'm thinking about atelecticus, I actually picture that the surfactant that's on that alveoli, that surfactant drying up and what that causes. And so I'm thinking of that pathophysiology the whole time, and how can I combat that as a AMT or as an EMT or what have you, anybody that can provide any type of care for this issue. How can I combat that? How can I make this better? Is it better for me? Does this person just need oxygen, or does this person need BiPAP or CPAP? You know, that's where you really start getting into those choices, that critical thinking phase. Does this person have a lot of fluid in the lungs? If there's fluid in the lungs, what exactly, if I'm thinking about pathophysiology, what is causing them not to get the proper oxygen doing that? Why does it sound like they're, breathing underwater? And then something else too, when you get into pharmacokinetics, from that point, then you start to break down how each one of those drugs is going to, or each one of those medications is going to affect that pathophysiology. At what point in the chain is it going to affect? At what point in the chain do you not want a certain drug to affect a certain, a certain illness or injury, but it may have good effects in others. Mostly when we're talking about alpha one receptors, beta one, beta two receptors, or that's what we're talking about, or that's what I'm thinking of a lot of times. So you got to really break down those pharmacokinetics, break down those drugs and how they're used. I was discussing it today about rhabdomyolysis, traumatic rhabdomyolysis, that peak T wave. Hey, I can't get a line. One of the firefighters like, hey, I can't get a line on this person. I can't get a good IV on this person. What do I do then? And I was like, well, what are you trying to do? What is rhabdomyolysis? And so we broke it down. And then I was like, what could help combat that? And we broke that down. And then we ended up coming up, I knew the answer, but I want them to figure it out. What drug could we give them that would in essence affect this issue in a positive manner? And we figured it out. They were able to figure it out after they pinged around a bunch of stuff, but they're thinking. You're thinking. Good stuff. All right, here's some good stuff here. It's talking about, yes, this is all good on this side, but child, when you're thinking about children, then you need to know child's tongue, how much larger and how much room it takes up than an adult's tongue. An adult's tongue doesn't. You still have plenty of room. Child's tongue does not. So any type of edema or anything like that could be a very real issue quickly for a child, whereas an adult, you may have a little bit more time. Also, positioning. So that head and neck, if you were to position that child, depending on their big bulbous heads, right? It's going to cause them to do like this, cause their head to bend down like this. It's a little exaggerated, but that could cause issues in the airway. Whereas a adult, it's less likely to be like that. They could be more of in a natural sniffing position. So maybe I need to prop that child up or put a towel underneath that child's shoulders, a folded up towel. Nasal cavity, you can see the differences there on how it's built. All right, so respirations. Respiration is a principal function of the lungs. There's two processes that occur during respiration. You have inspiration, which is inhaling, and you have expiration, which is exhaling. Ventilation is the process of moving air into and out of the lungs, right? Ventilation. So it's mechanical. Oxygen entering the alveoli from inhalation passes through tiny passages in the alveolar wall into the capillaries. The heart pumps the oxygen throughout the body. Carbon dioxide produced by the body's cells to the lungs and the blood that circulates through and around the alveoli air spaces. Carbon dioxide diffuses back into the alveoli and travels back up to the bronchial tree and out of the upper airways during exhalation. Carbon dioxide is exchanged for oxygen. Carbon dioxide is exchanged for oxygen, which travels in the opposite direction. I'm almost out of coffee. All right, so this figure here, it shows the exchange of oxygen and carbon dioxide during respiration. In side A that you can see, oxygen passes from the blood through capillaries to tissue cells. Carbon dioxide passes from tissue cells through capillaries to the blood. Okay, carbon dioxide passes from tissue cells through capillaries to the blood. In figure B here, in the lungs, oxygen is picked up by the blood and carbon dioxide is given off after that. And then the trees eat. All right, so inspiration. Not what I give people on a daily basis, but when we're talking about breathing. So inspiration, the stimulus to breathe comes from the respiratory center in the medulla. Right? Oblongata. The involuntary control of breathing originates in the brain stem. Okay? The involuntary control originates in the brain stem. Impulses for automatic breathing can be overridden to a point by voluntary control. The motor nerves of respiration are the phrenic nerves and intercostal nerves. If you remember this when we were talking about nerves a while back in anatomy. All right, so the combined actions of these structures enlarge the thorax and cause intrapulmonary pressure to fall below atmospheric pressure. Okay. Normal inspiratory reserve volume is about 3,000 milliliters in a typical adult, typical adult male, and 2,300 milliliters in a typical adult female. So normal inspiratory reserve volume. All right, expiration. As the chest expands, mechanical receptors in the chest wall and bronchioles send a signal to the apneustic center via the vagus, the vagus nerve, to inhibit the inspiratory center, and expiration occurs at that point. This feedback loop is known as the Herring-Brewer reflex. Y'all remember that term, the Herring-Brewer reflex? So this is what terminates inhalation to prevent overexpansion of the lungs, right? Normal expiratory reserve volume is about 1,200 milliliters. And the expiration lasts twice as long as an inspiration. This relationship is expressed by inspiratory-expiratory ratio, or IE ratio. The expiratory phase is short in a patient with tachypnea, right? So in your book, if you're following along in our book, I believe table 17-1 and 17-2 list the characteristics of adequate and inadequate breathing. So pathophysiology of this, right? For the body to receive the required nutrients and oxygen and dispose of waste products, adequate ventilation, diffusion, and perfusion must occur. Multiple complications can interfere with an ample intake of oxygen, right? So upper airway obstruction is caused by foreign body obstruction, trauma, inflammation, such as things like tonsillitis or epiglottitis, right? Lower airway obstruction is likely caused by trauma, obstructive lung disease. So, obstructive lung disease, sorry. Mucus accumulation, smooth muscle spasms, airway edema, chest wall impairment can be caused by chest wall impairment can be caused by trauma, things like trauma, hemothorax, pneumothorax, and then things like pleural effusion, pleural inflammation, neuromuscular diseases such as multiple sclerosis and muscular dystrophy. All right, then you have neurologic control problems, which can be caused by brainstem malfunction from the central nervous system with depressant drugs, stroke, or other medical neurological conditions such as trauma and neuromuscular disease, things like that. So, by rapidly assessing the patient and providing the necessary intervention to the patient, problems associated with oxygenation and ventilation can be minimized and avoided, regardless of the reason for difficulty breathing. You must be able to immediately recognize the signs and symptoms and know how to respond. That's why we use the mirrors, right? We auscultate. Well, you're fighting it, doing good stuff, taking care of yourself. I have a friend of mine that was diagnosed with MS, and she's been going strong. She has her bad days or her bad weeks at times, but she for the most part she still stays very active when she can. As much as she can. Like I say, every now and then she'll have flare ups, but other than that, though, she still stays very active. She's compliant with her medications and her other types of therapy, so it stays at bay. But yeah, it can definitely be done. Yep, that's right, and that's pretty much what she does. She just stays as active as she can. She's got young kids too, so that keeps her going pretty hard too. Yeah, she takes meds for hers when she has flare ups and such. She has to. There you go. Them youngins. I got a message today from my wife that my kid he didn't make green today. I guess they use colors at his school, so he didn't make green today. He was on red, and which he skipped right past yellow for whatever reason. Then she told me why. She sent me a picture, a screenshot of the message that the teacher sent her. So apparently, he told another student that his butt stinks. The student got upset and told the teacher. He's 8. Yeah, you ain't got time. You got young kids. You ain't got time to be laying down. You got stuff to do, stuff to take care of. But yeah. So he told this kid that his butt stinks, and his teacher put him on red. And I was like, well, I mean, Was he lying? I mean, was he just being brutally honest? So I don't know. The story behind it was even funnier. We won't get into it. It was funny though. All right, gas exchange interference. It's helpful to think of alveoli as small balloons at the end of a straw, right? So alveoli are made up of two types of cells. Pneumocytes. The cells are called pneumocytes. Type 1, almost empty, allowing for better gas exchange. And then type 2 make new type 1 cells. And they produce surfactant, which reduces surface tension and helps keep the alveoli expanded. Okay? Alveoli function best when they are kept partially inflated. By reducing the surface tension of the alveoli, surfactant makes it easier for them to expand. After foreign material gets into the terminal bronchioles and alveoli, it typically never comes out. And then collapsed, fluid-filled, and pus-filled alveoli do not participate in gas exchange. I don't know why my nose is itching. So conditions related to ventilation, perfusion, or both can prevent oxygen from reaching the bloodstream. Pulmonary capillaries are narrow and normally red blood cells to pass through only in single file at a time. Okay, people with chronic lung disease and chronic hypoxia often generate a surplus of red blood cells over time, which makes their blood really thick. Okay, so right-sided heart failure because of chronic lung disease is known as cor pulmonale. So carbon dioxide retention and hypoxic drive. The level of carbon dioxide in the arterial blood can rise for many reasons, right? Various types of lung disease may impair exhalation processes, or the exhalation process, not processes, process. The body may produce too much carbon dioxide temporarily or chronically, depending on the disease or the abnormality. If arterial carbon dioxide levels rise slowly to an abnormally high level and remain there, the respiratory center of the brain may work less efficiently. The failure of those centers to respond normally to a rise in arterial levels of carbon dioxide is a result of chronic carbon dioxide retention. So, hypoxic drive. We talked about this in past chapters. That's a condition where the brain gradually accommodates high levels of carbon dioxide and then uses a backup system to control breathing. To control breathing based on low levels of oxygen rather than high levels of carbon dioxide. The stimulus to breathe is the detection of low oxygen levels. If the arterial level of oxygen is raised, there is less stimulus to breathe. Giving too much oxygen to these patients may actually depress or stop their respirations. But we never withhold oxygen from a patient that needs it. So, in talking about that, what disease comes to mind whenever we talk about hypoxic drive? What main do we look at? That's right, COPD. And what does COPD stand for, Mr. Wade?
I can't even think of it off the top of the head.
So it kind of COPD. It kind of explains what it is in the title of it. That's why I ask. So it's going to be chronic obstructive pulmonary disease. Okay.
Pulmonary disease. Yeah,
Yep.
that's what.
Yep. Chronic obstructive pulmonary disease. Awesome. All right, so let's talk about some hypoventilation. When the lungs fail to work properly, the body cannot efficiently dispose of carbon dioxide and it accumulates in the blood. Excess carbon dioxide combines with water to form bicarbonate ions and hydrogen ions, also known as carbonic acid, right? Resulting in respiratory what? If you're building up in carbonic acid, we're now going to get into respiratory what? Acidosis. That's right. That's right. And what's something we would use to combat that? How will we combat that? So just think about that for a little bit. I'm not asking for an answer, but just think about how we would combat that as an AEMT. Okay. So acidosis can occur in hypoventilation if hypoventilation is not recognized, right? So impaired ventilation can be attributed to a variety of factors. The carbon dioxide level in the blood is also directly related to pH. Makes sense, right? So hypoventilating patients have respiratory acidosis. They're hypoventilated or not, the buildup of carbonic acid, so they're going to have that respiratory acidosis. As their carbon dioxide level decreases, their pH level decreases, right? Did I say that right? As their carbon dioxide level increases, their pH level decreases. I think I said that. I corrected it that time if I didn't. So many types of problems can cause patients to hypoventilate. Conditions that impair lung function, conditions that impair mechanics of breathing or that ventilation, right? Obesity hypoventilation syndrome. It's respiratory compromise related to morbid obesity. Conditions that impair the neuromuscular apparatus also. Serious injury to the spinal cord could be that, would be that. What do they call it? Guillain-Barre syndrome, Guillain-Barre syndrome, and then amyotrophic lateral sclerosis. That's a mouthful there. Botulism, caused by the bacterium Clostridium botulinum. So that also can cause that. So now we talked about hypoventilation. Let's talk about hyperventilation. So overbreathing to the point that arterial carbon dioxide falls below normal may be an indicator of a life-threatening illness, right? The body's attempt to compensate for acidosis can cause this as well. Buildup of excess acid in the body. It's telling the body saying, "Hey, we got a lot of acid here. We need to buffer this." So how do we buffer this? We need to breathe a lot. Start to breathe this up. Get more oxygen here. Let's get this out of here. It'll tell your brain or your medulla. It'll tell it to start making you breathe faster. And so you will. So the lowering of carbon dioxide is going to help to compensate for other acids also. Tachypnea without physiologic demand for increased oxygen causes respiratory alkalosis. And then alkalosis causes symptoms of hyperventilation syndrome, or what we would call a panic attack. Okay? So this is including things like anxiety, dizziness, numbness, tingling of the hands and feet that can lead to carpal pedal spasms, and sense of dyspnea, sense of breathing difficulty. Hyperventilation can be the body's response to illness and a buildup of acids in the body also. Hyperventilation syndrome is not the same thing. It's not the same thing. So this occurs in the absence of other physical problems, common during psychological stress. So causes of dyspnea. Dyspnea meaning shortness of breath or difficulty breathing. Again, many different medical problems can cause dyspnea. If the problem is severe and the brain is deprived of oxygen, the patient may not be alert enough to report shortness of breath. AMS, or altered mental status, is a sign of hypoxia of the brain, right? Patients with the following conditions often experience breathing difficulty or hypoxia. So pulmonary edema, hay fever, pleural effusion, obstruction of the airway, rib fractures, cystic fibrosis, hyperventilation syndrome, prolonged seizures, neuromuscular diseases, environmental or industrial exposure to toxic gases, carbon monoxide poisoning, drug overdoses. Okay? Just to name a few. As you treat these patients with disorders of the lung, be aware that one or more of these situations most likely exist. These situations are going to be gas exchange between the alveoli and pulmonary circulation is obstructed by fluid in the lung. This could be infection or collapsed alveoli, like a atelecticus. Collapsed alveoli, atelecticus. Remember us talking about that? It could also be alveoli are damaged and cannot transport gases properly, as well as air passages are obstructed by a muscle spasm or mucus, or weakened by floppy airway walls. Blood flow to the lungs is obstructed by blood clots, maybe. Pleural space is filled with air or excess fluid, so the lungs can't properly expand. So all these conditions prevent the proper exchange of oxygen and carbon dioxide. Pulmonary blood vessels may also have abnormalities that interfere with the blood and the transfer of gases. So besides shortness of breath, a patient with dyspnea may also report things like air hunger. Patient reports not getting enough air and a strong need to breathe. So they're saying, I'm not getting enough air, I'm not getting enough air. And then chest tightness. So it's described as an uncomfortable feeling in the chest, commonly reported by patients with asthma. Dyspnea is a common complaint in patients with cardiopulmonary disease as well. It may be caused by physical exertion made difficult because of the heart damage. And then congestive heart failure results in blood not pumping efficiently, leading to breathlessness. Pulmonary edema is associated with congestive heart failure as well. So severe pain can cause a patient to experience rapid, shallow breathing without the presence of pulmonary dysfunction. Breathing deeply may be a sign of pain that is due to expansion of the chest wall. When assessing a patient for common complaints of dyspnea, ask about chest pain. Ask about that. And ask about dyspnea when evaluating for chest pain. So moving on to upper or lower airway infection. Infectious disease may affect all parts of the airway. Infections can impair airflow through the airways, or infections that impair airflow through the airways are problems of respiration. Infections may cause dyspnea by obstructing airflow in the larger airways. As a result, why is this happening? My kid. You're driving me nuts. So, where was I at? I was talking about infections. There we go. Infections may cause dyspnea by obstructing airflow in larger airways as a result of production of mucus and secretions. Also, infections may also impair exchange of gases between the alveoli and the capillaries. In your book, table 17.5 shows the infectious disease that are associated with some degree of dyspnea. You can see here when it's talking about swollen epiglottitis or swollen epiglottis, which would be epiglottitis, right? Makes for a narrow airway. All right, so acute pulmonary edema is accumulation of fluid in the lungs. This causes a decrease in gas exchange, and it results in severe dyspnea. Severe myocardial damage caused by an acute or chronic problem results in reduced contractile force of the myocardium. Reduced contractile force of the myocardium. Okay. The left side of the heart, it cannot remove blood from the lungs as fast as the right side delivers it. So it's going to cause you issues. In pulmonary edema, fluid collects in the alveoli and lung tissue. The fluid separates from the alveoli from the pulmonary capillary vessels. And it interferes with the exchange of oxygen and carbon dioxide. So this may develop quickly, especially following a major cardiovascular insult. It could happen. Not all patients with PE or pulmonary edema, not PE, not all, I was thinking PE, that's pulmonary embolism. Pulmonary edema may have heart disease. Not all of them have heart disease. Other causes are going to include poisonings from smoke, toxic chemical fumes, or other pulmonary irritants. Traumatic injuries of the chest will cause that. And then exposure to high altitudes can also cause that as well. Patients with pulmonary edema that is cardiogenic in origin may present with signs and symptoms of a cardiac emergency. Patients with non-cardiac pulmonary edema tend to have a history of associated factors, including things such as a hypoxic episode, shock, chest trauma, recent acute inhalation of toxic gases or particles can cause that, and then recent ascent to high altitudes without first acclimatization or acclimatizing. All patients with pulmonary edema may also present with dyspnea, orthopnea, uh, fatigue, reduced exercise capacity, and pulmonary crackles. Let's take a quick 10-minute break before we start jumping into COPD right quick. So a quick 10-minute break. Let's see here. Whoops. I don't know why he's yelling. I don't know if anybody can hear him, but he is yelling. He's just being loud. I'm going to say he gets that from his mama.
This is the checkers game where grandson and granddad will bond.
All right. So 10 minutes. Let me swap this up here. right. I lost something. There it is. I couldn't find it. All right. Cole, are you on here yet? Are you back on yet? Okay. Well, apparently that's all I wanted to know. Okay, I can't find. I had that number for you. There it is. What was it? Chapter 12, you said? No. July 12th? Which one was it? I don't have July 12th. Okay, so July 12th, which was chapter 5. So chapter 5 was 0822. 0822. That's it. All right. So we are on chronic obstructive pulmonary disease. So this is a common lung condition. The slow process is the slow process that disrupts airways and alveoli. COPD is an umbrella term used to describe a few lung diseases, including emphysema and chronic bronchitis. So it's an umbrella term for all those. Cigarette smoking is the most common cause for this. The obstruction occurs in the bronchioles. Cilia are unable to move. The cilia are unable to remove excess mucus, and it creates a buildup. Chronic bronchitis results from overgrowth of the airway mucus glands and excess secretion of mucus, which blocks the airway. Yum, right? Patients have a chronic productive cough for at least 3 months per year for 2 or more consecutive years. Interesting. All right, pneumonia. Still talking about chronic obstructive pulmonary disease. So pneumonia. It develops easily when passages are consistently obstructed. Repeated episodes of pneumonia can lead to COPD. And emphysema is the most common form of COPD. So it's a degenerative condition characterized by destruction of the alveolar walls related to the destruction of pulmonary surfactant. It creates these large holes that are left in the lung that resemble an air pocket or a cavity. It's an irreversible condition. So most patients with COPD have elements of chronic bronchitis and emphysema. They also have a history of reoccurring lung problems. Are almost always long-term smokers. They consistently produce a sputum, right? They have a chronic cough, and have difficulty expelling air from their lungs. And also, they experience long expiration phases and wheezing. So, patients with acute COPD will complain of shortness of breath and gradually increasing symptoms over a period of days. They'll exhale through pursed lips, so when they're breathing. They'll complain of tightness in their chest and constant fatigue. They're constantly tired. And they have a chest with a barrel-like appearance, so what we call barrel chest. Barrel-chested. So this figure right here, it shows repeated episodes of irritation and inflammation in the alveoli that result in obstruction, scarring, and some dilation of the alveoli sac, characteristic of COPD. Figure A here is the normal alveolus. Figure B is the infection, when the infection produces mucus and swelling. And then figure C is a mucus plug creates an obstruction. See the mucus plug? It creates an obstruction and further dilation of the alveolus, as you can see here. So asthma. Asthma is the acute spasm of the bronchioles. It's associated with excess mucus production and bronchiolar muscle spasm. Just easily put. Common, but it's a serious issue as well. It's caused by a combination of bronchospasms, mucus production, and edema together. Status asthmaticus is a severe, prolonged asthma attack. It cannot be resolved with conventional treatment. It's a dire medical emergency as well. So wheezing is heard when asthma patients exhale. Breathing appears relatively normal, but you'll hear that wheezing sound. So asthma results from an allergic reaction, exercise, severe emotional distress, upper respiratory infection, or URI. Most patients are familiar with their symptoms and will have an appropriate type of medication with them. You have to listen carefully to these patients. They often know exactly what they need. So just listen to them. Or as my little boy says, just try. Just try. We have a joke with my little boy about my 8-year-old about just try, and it comes from he decided this was couple months ago, he decided he wanted to eat at Taco Bell. Well, his mama, they were just going on a short run, a real quick run. His mama said, I don't have the money right now to stop at Taco Bell. I don't know why you would lie to a child. Who the hell don't have money to stop at Taco Bell? They got like dime tacos and stuff. So anyway, she said, I don't have the money to stop at Taco Bell. It's probably because it was crowded. It looked crowded. Is what it probably was. And he said, what do you mean you don't have the money? And he said, I don't have the money to stop at Taco Bell and get anything to eat. And he said, well, just try. Just try. And she said, try what? I'm going to go up there and get money? You have to have money to buy stuff. And she said, he goes, oh, Mom, just try. Just try to go up there and get food. And I was like, or she was like, so I'm just going to roll up there, ask for the food. When I get to the window and them to hand it to me, I'm going to say, hey, I really need this food. It's good to go. And that will be just trying. So, or am I supposed to have money that just appears in my pocket as soon as we pull up to the window? So now we say everything, just try. If something can't be done or we can't do something immediately or anything else, we use the phrase just try. If it's something that you can't even remotely get done right then or you can't do or obtain or whatever, just try. Just try. He's quite entertaining. So anaphylactic reactions. Anaphylactic reactions is a severe allergic reaction characterized by airway swelling, dilation of blood vessels all over the body, which if you have a dilation of blood vessels that all over the body, what's that going to cause? Low blood pressure, right? It's going to cause low blood pressure, significantly lowers your blood pressure. Sometimes it's called anaphylactic shock. It can cause respiratory distress severe enough to lead to coma and death. It may be associated with widespread itching and an asthma-like condition. Also, most reactions occur within 30 minutes of exposure to some sort of allergen. There was a video that I wanted to share along the lines of this.
An epinephrine pen on.
Nope. Get out of here. All right. So this kind of goes with a couple things. One, the anaphylactic reactions. A lot of times, if somebody knows that they have allergies, so you know what I'm about to show you. And just to kind of rub on one of our instructors just a little bit of an incident that we had happen apparently at the boot camp. Somebody accidentally may have misused an EpiPen on accident and accidentally got themselves with the EpiPen. So this popped up and I deemed it appropriate. Even though it may not be appropriate, but we're going to go with it anyway. All right, here we go.
Oh, yes, exactly what you think is going to happen happens. She goes to inject her friend with an epinephrine pen, unfortunately has it upside down, and puts her thumb on the top, which is a monstrous no-no. Wham, bam, thank you, ma'am. She's in a ton of pain. So listen, I'm going to save you and your friends and anyone in the world that has to use an epinephrine pen ever again a ton of pain. very simple rhyme. You ready? Blue to the sky, orange to your thigh. Put your thumb on the top. Boy, you finna cry.
Yep.
This sucks. We gotta be in attention, huh? Is your first song? Yeah.
So remember that little rhyme. I suppose. Find my PowerPoint. Yep. So, sometimes things happen. Oh, Ty, there you are. I'm glad you got to see that. I'm glad you got to see that. Yeah, I'm going to say it would probably look painful going through a thumb. So blue to the sky, orange or red to the thigh. I don't want that one. Yep. How did a real one get in there? That's what I want to know. We'll move on. Oh my goodness. That's ridiculous. All right. Well, so when I came home from Afghanistan, I still had, the way that we had to leave and everything. I still had all my bags and everything else. I still had my kits with me. So I had atropine and all that stuff, auto injectors that were still in my bag, and I got rid of them. Man, I just got rid of those things because I kept them in one of my drawers for a long time. Of course, they expire or what have you, but I kept them in one of my drawers for a long time because I was like, I'm gonna use this for training, but I could never work up the nerve to use it for training, like to inject it into a box or anything else. I did it at home, but I just knew that the one time that I tried to use something like that for training, it would get screwed up and somebody would get jobbed, or it would come through the cardboard box and spray somebody in the face or something like that. So I just found it best to dispose of it. So I did, because things like that happen. I couldn't imagine, getting, if you were to screw that up and get a load of atropine doused into your body. That would suck. That would suck. So, spontaneous pneumothorax. Accumulation of air in the pleural space. What that is, it may occur, the accumulation of air in the pleural space, it may be partial or complete, a partial pneumothorax or a complete pneumothorax. Trauma is the most common cause. It may also be caused by certain medical conditions referred to as spontaneous pneumothorax. It may occur in patients with certain chronic lung infections, who are young and were born with weak areas of the lung. Also, who have emphysema and who have asthma. I'll tell you what else too. So people that get really sick and cough really hard. I've actually seen people that cough really hard get it. What's funny, or it's not funny, but it's kind of, A lot of times this happens in tall, lanky people. People that are very tall and they're lanky, thin chested. So I never have to worry about that because I've never been tall or thin. So I'll never have to worry about spontaneous pneumothorax as a result of being sick. But a lot of times that is the physique of the person that ends up with spontaneous pneumothorax whenever they get ill. Sometimes with any type of cough producing illness, and it's very painful. Apparently, so I've been told that it's very painful when it does happen. Hey, there it is. So patients become acutely dyspneic and typically complain of pleuritic chest pain. It's a sharp stabbing pain on one side, what they say. It's worse during breathing or with certain movements of the chest wall. Patients may present with subcutaneous emphysema, which is air bubbles trapped underneath the skin. In this, a lot of times you'll see it in this area. Okay. By listening to the chest with a stethoscope, you may note the breathing sounds are absent or decreased on the effective side. Patients experiencing minor problems may be pale, diaphoretic, tachypnic. Severe findings of this issue, you may find altered mental status or AMS, cyanosis, tachycardia, unilaterally decreased breath sounds, which is no good. None of this is no good. Local hyperresonance to percussion. Okay. Can anybody describe to me what hyperresonance to percussion would mean? So if you were to take right now and you're listening, you auscultate and you tap on your chest, it's going to sound somewhat solid, right? But if you have somebody that's got this issue here, spontaneous pneumothorax, and it's a complete spontaneous pneumothorax, then you could take, and when you're listening, you percuss that, and it's going to sound hyperresonance. It's going to sound loud or very hollow, almost like hitting a barrel, an empty barrel. Okay, but not metallic. So maybe like a plastic barrel, something like that. Some other things: subcutaneous emphysema, and then tracheal deviation, which is a late sign. So it's going to deviate towards the good lung. So it'll deviate towards the good lung. Patients with symptoms indicating a severe episode require immediate care to survive it. So something with tracheal deviation or something with that pneumothorax, since that is creating space in there, or however, if there's air that's getting in that area and it's constantly pressing on that one side, what else is it going to cause? After it starts pressing down on the heart for so long, what's it going to cause? All right, so what that also can cause, because you're putting a lot of pressure onto the heart, is cardiac tamponade. So a pneumothorax, that also counts for in trauma too, most likely in trauma. But that pneumothorax can turn into a cardiac tamponade. All right, so Pleural effusion. It's a collection of fluid outside the lung on both sides of the chest. On one or both sides of the chest. By compressing the lungs, the fluid is going to cause dyspnea. Fluid may be from irritation, infection, cancer. It can build up gradually, but patients often report sudden dyspnea. Should be considered in patients with lung cancer and shortness of breath. When you listen with a stethoscope to the chest of a patient with dyspnea resulting from pleural effusion, you'll hear a decreased breath sounds over the region of the chest where fluid has moved the lung away from the chest wall. Okay? So when you listen with a stethoscope to the chest of a patient with dyspnea resulting from pleural effusion, you'll hear that. That's going to be you're not going to hear breath sounds as well over that region that it's at, because the lungs are going to be moved further away from the chest wall. So that's why it sounds like it's decreased breath sounds. Patients usually feel better when they sit upright, so position of comfort. And definitive treatment for this is going to be fluid removal, so which has to be performed by a physician, by a chest tube, right? Given a chest tube. Now, pulmonary embolism. So, an embolus is anything in the circulatory system that travels to a distant site, where it lodges, creating a perfusion disorder by obstructing distal blood flow in that area. So it can be fragments of blood clots, or it can be other types of foreign bodies as well. Pulmonary embolism is a blood clot, or what we call a thrombus. Usually it's formed in a vein in the legs or in the pelvis. It then breaks off and circulates through the venous system and moves through the right side of the heart and into a pulmonary artery. It's going to decrease. It decreases, or it completely blocks the blood flow in that area. No gas exchange is going to occur in areas of blocked blood flow. Even though inhalation and exhalation are still occurring, you're not going to have that gas exchange. So what this is going to do is it causes ventilation perfusion mismatch. It may also occur as a result of damage to the lining of the vessels, hypercoagulability, slow blood flow in a lower extremity is what's going to create that. Some of the risk factors for this are going to include immobilized legs following a surgery or a fracture, recent surgeries, pregnancy, oral contraceptives, infection, cancer, sickle cell anemia, prolonged inactivity, or being bedridden can all cause these. So some signs and symptoms of this are going to be your dyspnea, your tachycardia, your tachypnea, varying degrees of hypoxia, and cyanosis, acute chest pain, and then also hemoptysis. Oh my gosh, man. Hemoptysis. I'm not even going to try, man. So coughing up blood. I say that like Porky the Pig. That's what they get when you get a fireman to teach medical classes. So obstruction of the airway. The patient with dyspnea may have some sort of mechanical obstruction. You see there, food occluding upper airway, air passage. You got to be prepared to treat that quickly. And how are you going to treat that? Some other stuff is you got the obstruction there on Bravo over there. The tongue's obstructing it. It's felt what they, when we think of fall back, we're thinking like the tongue fell back. It's just resting. It just rests back there on it. Rest. It doesn't really fold back. You don't swallow it per se. So obstruction of the airway in an unresponsive patient may be the result of vomitus, foreign object, improper positioning of the head so the tongue is blocking the airway. Always consider upper airway obstruction from a foreign body first in patients who were eating just before becoming short of breath. Like, this dude got some food up in there. All right, so environmental or industrial exposure. Potentially toxic substances can be inhaled. Often at industrial sites, this can happen. These include pesticides, cleaning solutions, chemicals, chlorine, and carbon monoxide. The amount of damage largely depends on the water solubility of the toxic gas. Highly water-soluble gases, such as ammonia, will react with the moist mucous membranes of the upper airway and cause swelling and irritation. Less water-soluble gases, such as phosgene and nitrogen dioxide, may get deep into the lower airway where they can cause pulmonary edema in or up to 24 hours later. All right, so cystic fibrosis. It's a genetic disorder. It affects the lungs and digestive systems. It's caused by a defective gene that makes it difficult for chloride to move through cells. It causes unusually high sodium loss and abnormally thick mucus secretions. Secretions in the lungs cause breathing problems and infections, and this leads to lung disease. The symptoms are going to range from sinus congestion to wheezing and asthma-like complaints. So you need to look out for respiratory insufficiency, signs of respiratory infection, and intestinal blockage. Often this causes death in childhood because of chronic pneumonia secondary to thick pathologic mucus in the airway. All right, so bronchiolitis. It's inflammation of the bronchioles in the lower respiratory tract due to viral infection. It's caused to metapneumovirus. It wasn't too bad. And respiratory syncytial virus, RSV. Primarily affects infants and children younger than 2 years of age. Signs and symptoms are similar to asthma. Asthma is rare in children younger than 1 year. Infant with first-time wheezing episode in late fall or the likely has bronchiolitis. So RSV, the common cause of illness in young children. It creates an infection in the lungs and breathing passages as well. It can cause severe respiratory illness such as bronchiolitis and pneumonia. It's highly contagious, so keep them away. It's spread through droplets of a cough or a sneeze, and it can survive on surfaces, including hands and clothing, for that. So, something about kids that end up with these RSV symptoms, and they get to where they can't breathe. A lot of times, if it's in the fall or the winter, a lot of times, if you have the parent wrap the baby up or the child up in good clothes and step outside, sometimes that can help alleviate it a little bit. Another thing is while you're doing your assessment, another thing is that I've used before is opening up the freezer, and while I'm doing my assessment, have the mom stand near the freezer, and they get that cool air, and that cool air kind of helps every now and then with that. That's not in our EMT, so forget I said that. Use it as a gee whiz later on. So croup, due to inflammation and swelling of the pharynx, larynx, and trachea. It's often secondary to acute viral infection of the upper respiratory tract. It's typically seen in children ages 6 months to 3 years. It's easily passed between children. It starts with a cold, cough, and low-grade fever that develops over 2 days. Hallmark signs are going to be stridor or a seal bark cough. Peak seasonal outbreaks in late fall and early winter are going to be it, and it's rarely seen in adults. Then often this responds well to humidified oxygen. We had our humidifier ran 24/7 in our kids' room for a while. Epiglottitis. So this is going to be serious inflammation of the epiglottis. It's usually caused by a bacterial infection that produces severe swelling of the flap over the larynx. It's predominant in children, but may occur at any age. The development of a childhood vaccine against okay, I don't know why I did that. Of Haemophilus influenza has dramatically decreased the incidence of this disease. It may completely obstruct the airway. So patients will look very sick. They'll look very sick. And it usually has a sudden onset. Patients will usually be in the tripod position and drooling. And then symptoms may include a sore throat, high fever, stridor, high-pitched inspiratory sounds. It may appear in adults or geriatric patients as well. Especially with other types of issues such as diabetes. It's also caused by different bacterial viral organisms can cause it as well, and it can potentially be life-threatening. And because as a result, or if you were to get it, deterioration can occur very quickly, which in turn would be a potential life threat, right? So we got to mitigate that. All right. Pneumonia. So this is a ventilation disorder caused by an infection of the lung parenchyma. So it's the 8th leading cause of death in the United States. That's crazy. The 8th leading cause of death in the United States. It's in a group of specific infections, not a single disease. At most risk, very, very young children and the elderly are at most risk for this. It presents as a local infection in the lungs that may cause atelectasis. If left untreated, it can become systemic, leading to sepsis and septic shock. Some of the signs and symptoms for pneumonia are going to be acute onset of fever and chills, productive cough and purulent sputum, or pleuritic chest pain, and then excess mucus causing pulmonary consolidation. Can do that as well. It can do it. So pneumonia, when you're listening to or you're auscultating breath sounds for pneumonia, what sound do you think it will make? Crackles. That's right. So it's going to sound like crackles. It's going to sound like the poppers, the packing poppers or what have you. It's going to sound like that. Or sound like the water bubbling almost when they're breathing. It sounds very... When you hear crackles, you'll know it. You'll be like, oh, yep, that's crackles. And always listen, very carefully. Listen in each lobe. Took my son to a pediatrician when he was very young, and the pediatrician was like, he's normal. It's perfectly normal. I don't know what's going on. Maybe he's just having fighting off something. That's what it was. Maybe he was just fighting off something. I said, he's got pneumonia. I said, I can hear it. He said, I just listened to him. I can't hear it. And I said, listen again. I said, listen again, very carefully. I said, I'm telling you. I said, I could hear it bigger than crap. And so he closed the door to the room, and he listened to it again. And I mean, as soon as he put it on the lower lungs, as soon as he put it on there, he said, oh, yeah, there it is. I can hear it. I can most definitely hear it. I said, I don't know how you missed that. And it's because he's seen so many patients a day, and that's the way we get too. He wasn't listening. That's not what he suspected, so he wasn't looking for that. And if you're not looking for it, then you're not going to find it. But so when I pointed it out and he listened again, then he heard it. So patient advocate. I'm a kid advocate. We don't get this kid better. It gets more expensive the sicker he gets. So we need to figure this stuff out quick. All right, pertussis. It's a airborne bacterial infection. Mostly it affects children younger than 6 years of age. It's highly contagious, once again. It's a pass-through droplet infection. So it can cause the feverishness with a whoop sound on inspiration after a coughing attack. Or the... Lord mercy. It's got cold-like symptoms, but coughing spells can last more than a minute. And then the child may turn red or maybe even purple, which is not a good color on kids. Frightened parents, they'll probably call 911 at that point, which, of course you would. All right, so airway obstruction. It's always consider the possibility of a foreign body when a young child becomes short of breath, especially crawling babies. Tonsil inflammation may also partially include an airway. Dysfunction of the tracheostomy, not the tracheostomy, but a tracheostomy, may also create an upper airway obstruction. Obstruction may be in the lower airway below the vocal cords as well. So trauma to the trachea may result in an injury that obstructs the lower airway. It can be from lung disease. It can be from mucus accumulation. It can be due to a smooth muscle spasm. Edema may also be present when a patient has been exposed to toxic chemicals or superheated air. It can cause it. All right. So up next, heart failure. So heart muscle is injured by a heart attack or other illness, right? The heart is not able to maintain cardiac output that meets the needs of the body. So this can result in pulmonary edema. Some of the risk factors for this are going to include hypertension or a history of coronary artery disease and or atrial fibrillation. Atrial fibrillation, right? Signs and symptoms of this: it may be difficulty breathing with exertion, a sudden attack of the respiratory distress, coughing, the feeling of being suffocated, cold sweats, and tachycardia be some of the symptoms. So, wet lungs versus dry lungs and cardiac asthma. Okay, I'm going to talk about that. So, wet lungs are associated with pulmonary edema. Dry lungs are associated with COPD. There's a table, if you're following along, table 17-6 in the text. In the text, it compares the difference between COPD and congestive heart failure. Breath sounds are very helpful, but can also be confusing in this situation. Patients with COPD are going to have wheezes. They have progressively worsening breathing over time. Most have trouble breathing on exertion, chronic coughing, and thick sputum. They do not have jugular vein distension, or there's a fly in here. They do not have jugular vein distension or dependent edema. It's usually long-term smokers with a thin barrel chest appearance can end up with this. Medications may also include some oxygen, or they'll be on home oxygen, bronchodilators, or corticosteroids. And there's a slower onset of symptoms. Patients with heart failure have elevated blood pressure, pedal edema, and a history. So pedal edema being swollen feet, right? Feet and ankles. And a history of heart failure. They may have no history of smoking, and they do not. So don't assume that all COPD patients have wheezing and all heart failure patients have crackles. Treat the patient, not the breath sounds. Good to go. All right. So before we jump off into this patient assessment, let's take a 10-minute break. This will be a good pausing point. Whoops. All right, so patient assessment. So your assessment, as we've always been talking about, should be calm and systematic. Patients in respiratory distress are usually quite anxious. It may be some of the most ill and challenging patients that you encounter. So that calm and systematic is going to be the winning combination. So the scene size up. First and foremost, your scene safety. Your first thought should be standard precautions. Personal protective equipment, your PPE. You're going to ensure a safe environment. If necessary, personnel with specialized training and equipment should remove the patient if he or she is in a hazardous environment. Determine the number of patients and whether or not you need specialized resources. Right? So that when it talks about assistance, it doesn't just mean higher echelon of medical care. It may need some sort of specialized resource. Consider the possibility of an airborne hazardous materials release. So consider that. Up next, you have nature of illness. If the nature of illness is in question, ask why 911 was activated in the first place. So your primary survey, recognition of life threats and initiation of resuscitation take priority over performing a detailed assessment. Okay? Let me repeat. Recognition of those life threats and initiation of resuscitation are going to take priority over detailed assessment. All right, so some signs and symptoms of life-threatening respiratory distress in adults, from most severe to least severe, are going to be altered mental status, severe cyanosis, absent or abnormal breath sounds, audible stridor, 1 to 2 word dyspnea, coughing, tachycardia of more than 130 beats a minute, abdominal breathing, changes in respiratory rate or rhythm, pallor or diaphoresis, the presence of retractions and use of accessory muscles, and tripod positioning, from most severe to least severe. So you're going to note your general impression of the patient. If the patient is alert or responding to verbal stimuli, you know that the brain is still receiving oxygen, right? If the patient is responsive only to painful stimuli or unresponsive, the brain may not be oxygenating well, and the potential for an airway or breathing problem is most likely. If there is no gag or cough reflex, you need to immediately assess the patient's airway status. Airway and breathing, you're going to determine if the airway is open and clear. You're going to determine if the patient is breathing or not. You're going to provide the appropriate oxygen therapy for a patient with spontaneous breathing, or immediately provide positive pressure ventilations for one who is apneic. If ventilating, determine if ventilations are effective. Are the ventilations effective? After assessing breath sounds, you want to evaluate circulation. You're going to assess the pulse rate, the rhythm, and the character. Rate, rhythm, and character. Tachycardia or bradycardia indicates the patient may not be getting enough oxygen. Okay? So, excuse me. Up next, you're going to assess for the presence of shock and bleeding. All right, so identify any life threats in your patient by the following signs and symptoms as well. Problems with airway, breathing, and circulation, your ABCs. Poor initial general impression, an altered mental status, potential hyperperfusion or shock, chest pain associated with low blood pressure, severe pain anywhere, excessive bleeding. If the patient's condition is unstable and there's a high life threat, address the life threat and then proceed with rapid transport from there. If the patient's condition is stable and there are no life threats, you may decide to perform a thorough secondary assessment on scene after obtaining the patient history. So, assessing breath sounds, auscultating breath sounds, or lung sounds is one of the most important vital signs for your patient in respiratory distress. So, lung or breathing sounds is one of the most important vital signs for your patient if they're in this respiratory distress, and the importance of that's going to be, or you are going to be the person that is going to be listening to that. And the more, like I said before, the more often you listen to lung sounds, good and bad, once you know what a normal breath sound sounds like, then you can start to learn what a abnormal breath sound sounds like. So you're going to listen over a bare chest. If you listen over a shirt or anything like that, then you're going to hear rubbing. It's going to sound almost like pleuritic rubbing, or it could be mistaken as pleuritic rubbing. The diaphragm of the stethoscope must be in firm contact with the skin. And then you're going to bring your patient to a sitting position at this point. So you're going to need to determine whether your patient's breath sounds are normal or abnormal. Like we talked about before, in some of these, vesicular breath sounds represent air moving in and out of the alveoli. Bronchial breath sounds represent air moving through the bronchi. Adventitious breath sounds are decreased, absent, or abnormal. You're going to listen for the full respiratory cycle. When assessing for fluid collection, you're going to pay special attention to the lower lung fields. You want to hear clear flow of air in both lungs. So the lack of air movement is going to be a significant finding, right? Don't confuse absent and clear breath sounds. You're still going to hear that whoosh of air. You need to listen between absent and what is clear. Okay? The lack of movement in that air is going to be what you find to be the significant finding in that. So some abnormal breath sounds are going to include crackles, fine crackling sounds of air trying to pass through fluid in an alveoli, like bubbles, right? Or the sound of the bubble wrap. Rhonchi. So that's a lower pitched sound caused by secretions or mucus in the large airway. Stridor. Stridor is going to be a high pitched sound on inspiration. Okay. As air tries to pass through an obstruction in the upper airway. So like burns, things like that. That can be, you can hear that in stridor because of the edema. Wheezing is going to be a high-pitched whistling sound, typically heard on expiration, and indicates constriction and or inflammation of the bronchus. Okay. Pleural friction rub is going to be a squeaking or a grating sound that occurs when the pleural linings rub together. Snoring sounds are indicative of a partial airway obstruction as well. There's a video on Facebook today of really good sounds of snoring. You can hear it from a mile away. Dude was threatening another guy with a baseball bat, and the guy without the baseball bat ended up beating the brakes off the guy with the baseball bat. And the real takeaway from it was the type of respirations that were going on, along with the snoring respirations. You could hear the snoring very well. Sounds just like snoring. The dude was asleep. I would play it, but there was a lot of cursing. All right, so history taking. With patients in respiratory distress, the sample history can be obtained from the family or other bystanders if they're present. You're going to limit the number of questions to pertinent ones. Be sure to ask the following questions about a patient in respiratory distress. So the following questions. What is the patient's general state of health? Has the patient had any childhood or adult diseases? Have there been any recent surgeries or hospitalizations? Have there been any traumatic injuries? Is there any dyspnea or chest pain? Boom, ba boom, 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 ba boom. After this, if time allows, you can also ask the patient their immunization history. So you can also ask about previous episodes, medication allergies, and current medications. The patient's subjective description of the problem is an accurate indicator of the acuity of this episode if the disease is chronic. Okay? So find out what the patient has already done for the breathing problem. Pay close attention to the medications the patient is currently taking. If medical control permits, you may administer a bronchodilator via nebulizer. What would be a good bronchodilator that you would give by nebulizer? Let me see it. Albuterol. Yep. That is correct. You may need to reassess breathing frequently and be prepared to assist ventilations in some severe cases. So find out whether the patient has any allergies or history of medication reactions also. Use OPQRST-I pneumatic to determine the specifics of pain and obtain a specific information about the breathing problem. So onset being when did the breathing problem begin? Provocation or palliation would be what makes the breathing difficulty worse or better. Quality being how does the breathing feel. Radiation or region. Does the discomfort move? You could ask for severity. How much of a problem is the patient having? How much of a problem are you having? They can tell you. Is the problem continuous? Is the problem continuous or intermittent? What has been done to alleviate the problem prior to EMS arrival? Does the patient have a cough? Is it productive or non-productive? If it's productive, what color is the sputum? If you want to look at that. Is there hemoptypus? Wheezing, fever, or chills? Is there any increased sputum production? And then, has there been any exposure to smoke, or does the patient have a history of smoking? Those are all good questions. So some chronic respiratory conditions. Patients with chronic conditions may have long periods in which they are able to live relatively normal lives, but then sometimes experience acute worsening of their conditions, right? So chronic lower airway obstruction makes it difficult for patients to breathe deeply enough to clear the lungs. If a new infection of the lung occurs in a patient with COPD, the arterial oxygen level may fall rapidly because of that. Patients with COPD usually have a long history of dyspnea with a sudden increase in shortness of breath. They rarely have a history of chest pain. The pulse is rapid and occasionally it can be irregular. Pay attention mostly to the respirations themselves. Patients with asthma may have different types of triggers. It's important to try to determine what may have triggered the attack, so that it can be treated appropriately. So patients also with heart failure walk a fine line between compensating for their diminishing cardiac capacity and decompensating completely. Your history taken should include obtaining a list of all of their medications, paying special attention to the events leading up to the current problem. Sometimes they will hand you a bag full of medications. All right, your secondary assessment. So that's going to be more in-depth assessment of the body systems. It's going to address the specific chief complaint. It's going to include physical examination and taking vital signs. You perform this after identifying and treating life threats. After that, you're never going to compromise an assessment and treatment of breathing problems to conduct a physical examination. Don't do it. Keep an open mind, gather a complete history as possible, and perform a physical examination. The physical examination, it may reveal additional pieces of the assessment and treatment puzzle for you. So it may also provide you with some clues for what's going on as well. So you're going to conduct an in-depth assessment when a patient complains of shortness of breath. A change in mental status is one of the early warning signs of respiratory inadequacy and indicates a lack of perfusion to the brain, which is serious. Look for, when you're looking at this patient during your physical examination, you're going to look for symmetry of the chest, adequate chest rise and fall, and evidence of any type of retractions or accessory muscle use. So also check the patient's respiratory status and slowing the respiratory rate in the face of an unimproved condition is going to suggest physical exhaustion. Respiratory patterns, they're going to be listed for you. They're in a table in your book, I believe 17-8. So you're also going to look for signs of increased working of breathing in these patients as well. Okay, so many smokers and people with chronic respiratory diseases, they're going to cough up sputum every day. So you need to determine the color and the amount, if the amount of sputum has changed. So a secondary assessment of the cardiovascular system itself, it should include things like checking and comparing their distal pulses. So we've talked about it before. Whenever you come up and you talk to this patient after you introduce yourself, you're going to you introduce yourself and you ask them if it's okay if you proceed with your assessment, get their permission, and then from there, what I like to do is as I'm talking to them, I check their pulses using both wrists. I'm feeling on both wrists, and you're comparing at that point. Also at the same time, you can reassess their skin condition, and then you need to be on the lookout for any type of bradycardia or tachycardia involved in this. And then also on your way, check for any type of trauma or retractions in the chest. A barrel chest is going to indicate a presence of long-standing COPD, like we talked about a few slides before, right? The numbness, tingling, and carpopedal spasms may be associated with hypocapnia, resulting from periods of rapid or deep respirations. Blood pressure, it can be auscultated when possible to obtain the systolic and diastolic measurements. Auscultation of blood pressure is going to be your full blood pressure procedure. So using your ears, and then also using the actual tool itself. And then we've talked about before being able to feel for your blood pressure. We talked about that, doing it by hand. So if you're like in a noisy environment or you can't quite hear it or anything else, maybe you can feel it. You can do an auscultation over palpation. So at that point, the systolic blood pressure is going to be, you'll get the systolic number, the top number, but then you'll put over P, over palp, right? We've talked about that before. If you're in an environment where you can't hear, that's usually when you can palpate. It is an alternative. It's not as accurate, but it is an alternative. So when you do the feel for skin temperature or look for color changes, you can do it in the extremities and in the core of the body to get that comparison, right? So cyanosis, as you know, blue, is going to be an ominous sign that's going to require immediate aggressive intervention. It's important to assess the neurologic system frequently, so you can kind of see in there any changes. Do your trending. So check that mental status constantly and determine if activity can be described anxious or restless. So monitoring devices, if available, a pulse ox is a non-invasive device that's going to measure that percentage of hemoglobin for you. Pulse ox readings may be inaccurate in the presence of certain conditions that abnormally bind hemoglobin. So diagnostic testing provides a baseline and indicates the severity of respiratory difficulty. End-tidal carbon dioxide, or EtCO2 monitoring, it's going to measure the amount of exhaled carbon dioxide, right? It's going to be accomplished through a device that's going to measure the amount of carbon dioxide exhaled during a specific time and plots the resulting values. You'll see that as a waveform. So the exact exchange or the exact percentage of carbon dioxide contained in the last few milliliters of the patient's exhaled air can be measured using the special sensor. The peak flow meter, it provides a baseline assessment of expiratory airflow for patients with obstructive lung disease as well. Use them. All right, so reassessment. So you're going to repeat the primary survey and maintain an open airway. You're going to monitor the patient's breathing. You're going to reassess the circulation. So it all starts back over, right? You're going to determine if there's been any changes in the patient's condition. You're going to confirm the adequacy of your interventions and patient status. If the changes you find are improvements, continue the treatments. Be prepared also, though, to modify treatments if the patient's condition is deteriorating. Be prepared to assist with ventilations with a bag valve mask at any time, at any point during that. Monitor the skin color and temperature. It's a pretty good indicator. Also, reassess and record your vital signs. Every 5 minutes for unstable, every 15 minutes for a stable. Okay? All right, so emergency medical care. All right, so we're going to perform some standard interventions. Oxygen to keep the saturation above 94%. And an IV line, they're typical interventions. Psychological support is an important consideration for a patient with dyspnea. So you need to constantly speak with assurance and assume a calm, professional, caring demeanor to reassure your patient. Okay. Decrease the work of breathing. So the muscles must work harder during respiratory distress, right? Tremendous workload uses large amounts of energy, which requires even more oxygen and ventilation. At some point, your patient will tire out and be unable to continue the necessary work of breathing. Some of your patients with asthma may compensate for days, hoping that their steroids or their bronchodilators will resolve the attack, right? And it may not. The supine position, with or without the legs raised, especially for an overweight patient, causes the abdominal organs to compress on the diaphragm, which is going to cause issues. Abdominal distension with air or blood compound, it's going to compound the situation as well. And then you're going to remove any constricting clothing, such as belts, tight collars, from the patient. And then do not make your patient walk. Do not make the person walk. Don't be that. All right, go get the stair chair. Same thing with chest pain patients. Do not make your chest patients walk. Go get the stair chair if you got to move them any, or put them on a backboard or what have you. But if you want to keep them in a position of comfort, go get that stair chair. Just go get it. It's not about your laziness. Lord mercy. You start feeling old feelings start to well back up. And learn how to use a stair chair efficiently, quickly. Then it's not so bad if you know how to use it. You're going to provide supplemental oxygen. So this is essential. It's essential to provide supplemental oxygen to any patient who needs it. Any patient who needs it. You're going to administer oxygen in the concentrations necessary to be effective. Okay? To be effective. We're not just going to load them the hell down. We're going to be effective. 94% is our low goal to do that. We don't want to overload them. We don't want to cause them distress. Because another thing is, too, if you're feeding them oxygen without a humidifier, that causes you to dry them up, right? You can dry them up and cause other issues. Patients who are not breathing adequately should receive a bag valve mask, or BVM, with supplemental oxygen, or a more advanced airway management technique from there, right? Pulse oximetry is it's a useful guide to oxygenation if it's accurate. Uh, Safe to administer oxygen in concentrations less than 50% to almost anyone. Oxygen concentrations higher than 50% should be reserved for patients with hypoxia that does not respond to lower concentrations. Use 100% oxygen. The use of 100% oxygen, it should be limited to the shortest period necessary, right? uh, don't ever hesitate to administer oxygen aggressively to a patient who needs it. And then oxygen saturation of 100% should be avoided. I repeat, 100% should be avoided. Because you're overloading. You can be overloading at that point. Or if they have O2 sat of 100% and you're looking at it on a pulse ox whenever you first put it on them, there may be another issue. So consider the possibility that the pulse ox may provide it could be a falsely elevated assessment of the patient's overall level of oxygenation. Also, in the context of very short transport times, very short being less than an hour, there's essentially no danger to hyperoxia, and oxygen therapy should be employed liberally. So, unless you're a long transport. So, administering a bronchodilator. Patients who do not have bronchospasms usually benefit only slightly from aerosol bronchodilators. Bronchodilators are of little value in treating conditions such as pneumonia, pulmonary edema, and heart disease as well. So, respiratory medications. Most common medications used for dyspnea are called inhaled beta agonist. Inhaled beta agonist. Typical trade names are going to be like your Proventil, your Ventolin. That's a pretty common one. Metaprel and Brethine. Brethine's a pretty common one as well. Action of most of these medications is to relax the smooth muscles within the bronchioles of the lungs. Bronchial dilators relax the smooth muscles around the larger bronchi, and they're important therapy for bronchoconstriction. Fast-acting bronchodilators provide almost instant relief for those patients. Bronchodilators they do not reduce swelling. They don't kill bacteria. They don't push fluid out of the lungs or open closed alveoli. Okay? Secondary bronchoconstriction could be reversed with a bronchodilator though. So medication specifically designed for aerosol use, like a hypertropium, is available in a meter dose inhaler or an MDI. Anticholinergics have emerged as a central component in the management of COPD as of late. So some common side effects of inhalers used for acute shortness of breath are going to include increased pulse rate, nervousness, and some muscle tremors as well. Right, so aerosol therapy. It's a simple method of delivering medications such as bronchodilators. Aerosol nebulizers that delivers liquid medications in the form of a fine mist. To generate the optimal particulate size, most nebulizers need to have oxygen or a gas oxygen flow of at least 6 liters per minute. So a nebulizer, it can be attached to a mouthpiece or a pipe. It can be attached to a face mask or a tracheostomy collar, or it can simply be held in front of a patient's face. The smaller the amount of mist the patient inhales, can't do what? Yeah, they can do nebulizers.
I'm talking about with epi in there.
What, did I miss something?
No, you're saying epi to a nebulizer.
You're talking about a duo neb because you can do that as well.
Yeah, you can do duonebs.
Oh, okay. I didn't know if you could, administer epi through a nebulizer, being an EMT.
Did I say that?
No, I was thinking we couldn't do that.
Okay. Now we can do, so you can do the duonebs, you can do hypertropium, you can do albuterol. What else? I have to get my list out again.
Do you ever administer epi through a nebulizer?
No, I've never done it.
I was just wondering. I'd never heard of it.
I have administered it down a tube, though. Down an ET tube.
I guess that was before the IO drill.
It was, well, sometimes people don't check the bag off appropriately, and it's not the needles aren't in there sometimes, or they forget it, or it gets lost, or it gets left somewhere. I mean, it can be a number of things, or you just did it. You just tried it out. We practice medicine. You know that, Ty. We practice medicine. I just practiced a lot. Where was I at? So we were talking about the smaller amount of mist that the patient inhales, the less medication he or she is going to be receiving. Blow-by and mouthpiece treatments are ineffective if patients continually turn their heads or remove the mouthpiece to answer questions. They'll sit there and talk and they'll hold that mouthpiece. It's no good if they do that. So just while they're doing it, just let them do their thing. Get them to breathe. Breathe in their mouth, what have you. I can vouch that yes, they are used a good bit. I used them all the time. So just about for most of my patients, if they code, if I have a patient code, he's going to get an IO, or he or she is going to get an IO. It's fast. Yeah. We went through them IOs like candy. If you were unconscious when I got there, you might get an IO. Maybe not. I'm not going to sit there and look for a vein on a pulseless apneic patient. And I've used multiple IOs. I've used multiple IOs on one patient. Yeah, it's good stuff. IOs are. So a quick way to provide a cooling mist to the swollen upper airway of a patient with burns or a child with croup is to give aerosol treatment of saline solution or sterile water. That's good for it too. I've had them days. 14 calls, 12 transports. I've had them days. And then you got to do all the documentation for that. Man, I can't tell you how many times that I was like, I want to be an EMT again. Take my card out and just be an EMT again. Yeah, okay. You drove by the base, 28th Street. Good old 28th Street. 28th Street used to be the deciding factor. If I was going to get an IV, if I didn't have it by 28th Street, you weren't going to get it. But now, some of 28th Street, they still got the bad part of 28th Street, but some of it they repaved, so it's not like it used to be. But yeah, 28th Street there, you knew if you were going to get an IV or not. If you didn't have an IV by 28th Street, you can hang it up. It was going to be a pretty rough ride down 28th Street. Terrible. What's next? So it's possible to give repeated treatments to patients that are having bronchospasms. And then tachycardia is almost always already present in patients with dyspnea. So be sure to consult med control or local protocols for any type of guidance. I agree. All right, MDI, or meter dose inhalers. So a miniature spray canister, it's used to direct medication through the mouth and into the lungs. Small and easy for patients to carry and use, and it's convenient. Usually the delivery method of choice for bronchodilators and corticosteroids in the home setting is going to be your MDIs. Document how often the patient's been taking an extra puff of that MDI if it's out of the ordinary for them. So make sure you ask. Each MDI on the ambulance should ideally be equipped with some sort of spacer like you see here in the picture. The spacer is a device that's going to collect the medication as it's released from the canister, and it's going to allow more to be delivered to the lungs and less to be lost to the environment. So you want to achieve the proper technique when using an MDI. It requires constant enforcement or reinforcement to that patient. So there's your steps. So steps to ensure while administering MDI. The mist from an MDI, it must enter the lungs. Some patients mistakenly blow into the spacer. They're not supposed to do that, right? Yeah. Many of the spacers, they have a harmonica sound if the patient sucks too hard on it. Patients should try to inhale the medication deeply and then hold their breath for a few seconds. Sometimes you'll see that they'll breathe it in and then they'll automatically go out and you'll see that little bit of fog come out. That's your medication that's coming out. So make sure that the inhaler contains medication. That's an easy way. Keep the spacer and the canister holder clean. After using a corticosteroid inhaler, patients should rinse out their mouths with water or mouthwash because it'll create issues. Corticosteroid will. Some contraindications for the use of an MDI are going to include a patient that's unable to the patient is unable to help coordinate inhalation with depression of the trigger of the MDI, or is too confused to effectively administer medication through a small volume nebulizer, that's going to be an issue. If the MDI or the small volume nebulizer is not prescribed to the patient, you're not going to do that, right? If you didn't obtain permission from med control, or it's not permissible by local protocol, that's going to be a contraindication. The patient that has already met the maximum prescribed dose before your arrival, that'll be a contraindication. That's why it's important to ask. If the medication's expired, you're not going to use it. If there's any other contraindications, there are other contraindications that are specific to the medication also. So about 5 minutes after the patient uses the inhaler, repeat the vital signs and the primary survey again to see changes. Transport the patient to the clearest, most appropriate emergency department. And then while en route, you're going to continue to assess the patient's breathing. Using an MDI as well as administering nebulized treatments, it may be done en route. Dry powder inhalers. So each time the device is opened, the small plastic blister that holds a dose is rotated into position. The patient is going to then, it pushes a small lever to puncture the blister and presses the disc to his or her lips over the opening, and it inhales deeply to suck the powder out of the device. I personally have not used one of these, so it's really hard for me to describe how that's going to work. So it's reasonably confected, it's reasonably convenient and easy to use. Apparently, it's rarely used during emergency care itself. That's why we really don't carry them a whole lot. With this kind of stuff, you're going to consider a fluid balance. So a common practice to give a fluid bolus to younger patients with these conditions. In any older patient or other patient with cardiac dysfunction, administering too much fluid could cause pulmonary edema. Always assess breath sounds before and after giving a fluid bolus to make sure that the patient does not become overhydrated. Like we talked about, we're not just going to dump, right? All right, support or assisted ventilations. If the patient becomes fatigued, breathing might be you may need to support that more aggressively. Some patients may simply require a bag valve mask for a short period. Trying to assist breathing for a patient who is already breathing on his or her own is one of the most difficult interventions because you got to time it, right? It's important to be confident in your BVM technique when you do it because you got, like I said, you got to kind of time it with your patient. Gastric distension and vomiting from over-aggressive ventilation can complicate an already worsening situation, right? So you want to make sure, like I said, timing. Be confident. Practice BVMing. All right, continuous positive pressure, or positive airway pressure, CPAP. Use this to treat obstructive sleep apnea and treat respiratory failure. Many people with obstructive sleep apnea wear a CPAP unit at night to maintain their airways during sleeping. This type of CPAP, it may be applied via nasal pillows or a nasal mask, a face mask that resembles a typical mask used for bag valve ventilations, or a mask that covers the entire face. It's not the same type used for critically ill patients. Not the same type. The CPAP used as therapy for respiratory failure is almost always delivered through a mask that is secured to the face with some type of strap, and then also you're loading it full of oxygen as well. So the success of CPAP is inversely related to the patient's respiratory rate soon after the application of it. If the rate increases, the therapy is more likely to fail. If the rate decreases, the therapy is likely to succeed, right? You're not going to struggle with a patient who's unwilling to use the mask. It's where you have to really speak to your patients and get them convinced that it's helping them. So bilevel positive airway pressure, different than CPAP. One pressure can be delivered during inspiration, and a different pressure can be delivered during exhalation. It's more comfortable to use. It causes pressure variation in the chest, which also allows for more normal blood flow, and it's more complex and expensive as well. Here's another assessment and management of specific conditions. We're not going to get too far into this. We will be beating patient assessment down. So we'll be beating this down. So a big one there, aggressively monitor the patient's ability to protect his or her own airway. That's very important. Get through that. So tracheostomy dysfunction is everybody's favorite. Children with chronic pulmonary medical conditions may also use a home ventilator connected by a tracheostomy tube. It's going to be placed in the neck, and some of the complications with these are going to be obstruction by secretions, mucus, or foreign bodies. You got to suck them out, right? Bleeding, leaking, dislodgement can happen, and infection. You're going to establish a patent airway and place the patient in a position of comfort, and you're going to suction it to clear the obstruction. You know, if you're unable to clear the airway, you're going to consider a paramedic intervention from there. No way, man. It's an AMT skill. We had a flat can't respond. Once the obstruction is clear, you're going to oxygenate your patient. You're going to treat based on presentation at that point. Geriatric patients may have a tracheostomy tube in place because of airway obstruction. Laryngeal cancer, severe infection, trauma, or an inability to manage secretions can be an issue. It can be obstructed by secretions, foreign bodies, or airway swelling. And the stoma itself can become infected. The actual hole itself around, right? You know, the actual hole in the throat become infected. Establishing airway patency is the immediate goal for that. Went over this already. And that's it. That is all, folks. All right, so tonight will be your test, or you'll be turning in a test tonight, and then you'll have one opening up also tonight. So one will be closing tonight, and then one will be opening tonight. Tonight. Let me check it out. I don't know why this is always so slow. All right. Chapter is this? 17? I have to go in here and make sure that I put the questions in there. Great. Especially with see, like on this one, I didn't even put a code on here. I'm losing it, I guess. So chapter 17, right? I'm sorry, 15? Is that right?
I thought it was 16.
Chapter 16 was the last one. It was the other day. It was yesterday's class. Did I label that inappropriately on my... Hold on, let me look. Come on now. Chapter 17, Respiratory Emergencies. I don't know why I have on here 15. That's not where I need that. Chapter 17. Today's the 18th, right? Just in case. I had chapter 15 wrote down for whatever reason. All right, so today's 4-digit code is going to be 8745. 8745. Eight, 7, 4, 5. And to make sure I enter it in. All right, did everybody get that? 8745. Good. You were the main one, Cole. Want to make sure that you got that. Don't forget to put your name in there, or the ARES form for participation for attendance. Even though I take my own attendance, I asked about that if my attendance sufficed. I was told it does well. It's a backup, but the primary is going to be on the ARES site. So put that in there. Does anybody have any further questions of me before I stop recording? Anything pertaining to the class or any questions? Alrighty. Well, I'm going to stop recording now.